So also young dogs can develop wobbler syndrome due to this osseous associated presentation of cervical myelopathy. So again, we try to separate disc-associated compression from osseous-associated compression, but remember, many times we are dealing with components of both these phenomena. We can see a little bit of a breed predisposition. So the disc-associated is usually seen in Dobermans and Weimaraner at older age 6 to 8 years, whereas the osseous, the purely osseous-associated compression is seen in Great Danes, in young Great Danes of 1 year of age, sometimes even younger. And in that case, we have an absolute vertebral canal stenosis. And it can relate to multiple sites. So not one side, but 2 or 3 or 4 sites may be affected. So if you look at the imaging that is being used for this disease, over the years, what is described in literature, 10 years, 15 years ago, before we had CT scanners, routine availability to CT and MRI scanners, we diagnosed this disease with a myelogram. So a myelogram is a contrast study, it's a radiographic study, where we inject a contrast agent in the subarachnoid space. And it's excellent for diagnosing disc-associated compression. It also easily allows dynamic images. So you make one image in extension, one inflection, so you can introduce the dynamics in your study. Then later, when CT scanners and MRI scanners became available, these were the preferred techniques because they give a lot more information on bone, on disc, on ligaments, on the spinal cord. But the disadvantage of these techniques is that it's far more difficult to introduce the dynamics with these studies. It can be done, but it takes more time for the study. And then you need a radiologist that is very willing to do these dynamic studies in CT or MRI to get you the dynamic information. Nowadays, MRI is more or less the standard way to diagnose this disease. And then we try to make a series MRI with extension and one without extension. But if we talk about MRI, we really also need to talk about low field MRI and high field MRI, and especially low field MRI. I would not prefer as a technique for wobbler. So if you have to choose from a CT scanner or a low field MRI, I would go for CT. The CT gives far more information than a low field MRI. What is low field is 0.2 Tesla. High field MRI starts at 1.5 Tesla and up. So this is the myelogram. So here's the native X-ray. No contrast is added. We see the changes in the bone. Abnormal vertebra. Here we also have an abnormal end plate vertebra. We have some disc collapse. We have shifting of the vertebra, instability. And then if we add the contrast, this is the myelogram, and we extend the neck, we see the compression. Maybe a little bit compressing starting here also, but this could still be normal, but this is not normal. This is the site of the clinical, this is the clinically relevant site. And then if we flex the neck, we see that the compression is somewhat less, but it's still there. But you can now clearly see the dynamic nature of the disease. And this is an MRI. I think this is low field MRI. See, the low field MRI, the resolution of this is far less than your myelogram. Let me go back. See how sharp this image is, myelogram. And then this is low field MRI. Of course, we see a lot more, but the resolution of the image is not that great. But we see the spinal cord, we see the disc, normal discs, we see the black disc, the degenerated disc, we see the subarachnoid fluid here. But if we want to see something about the bone on MRI, it's quite difficult. MRI is not so good for bone. So we see the spinous processes, maybe, but the vertebrae are difficult to discern. And now this is the transverse slice, this is the healthy disc slice, the transverse slice. We can see the nucleus pulposus here, the spinal cord. And then at the affected side here, we have the stenosis and the disc protrusion that touches the spinal cord. So we can see a lot on MRI, but not everything. So let's talk about treatment of this disease. Conservative treatment, there is certainly a place for conservative treatment with this disease. Then we have to think about non-steroidals or steroids, gabapentin, opioids, harness for life, animal physiotherapy, hydrotherapy. And this may have a good outcome in about half of the cases. Half of the cases are doing well with this type of treatment for a longer time. So we have to remember that there is a place for conservative treatment. So how about surgical treatments? What is the indication for surgery? Well, if we have a dog that has severe neurological deficits, this is not the best for conservative treatment. Or if it does not respond to medication, then there's only one option left, and that is surgery. So we need a diagnosis with our imaging. We need to know, is it single lesion, multiple lesions? Is it dynamic in nature, or is it truly static? If it is only truly static in nature, we could do only ventral decompression. But that's not what we're talking about today. We are talking about dynamic lesions. And very important, in certain breeds, we also need to have a wide scope for other diseases. Don't go in there thinking, I'm going to treat this dog, a Doberman, that is showing a lot of neurology. It may also have a heart disease. It may have a liver disease. So Dobermans are known to have quite a number of diseases at the same time. So we have to check hypothyroidism in Dobermans, all the Dobermans, bleeding testing for Van Willebrand's disease. If you go in there in surgery, this is invasive surgery, cervical spine surgery. If you go in and you encounter a problem with bleeding, then you have a problem. Cardiomyopathy, it may not be clinical yet, but if you put him under anesthesia for a long time, 2 or 3 hours with spine surgery, it may get clinically relevant. So you have to check that. Same with the liver. So I just made a list of the techniques that have been described in the literature, and we only talk about some of them, especially the ones that that are dealing with the dynamic nature of the disease. And also the current status, where we are, and maybe where we go to. And just a little history on the techniques that have been used for the dynamic lesions, starting with the Harrington rod. This is maybe already 20 years ago. The Lubra plating has been used, Steinmann pinne with bone cement, into-body cement plugs. And these are the more recent techniques, the screw and washer, cervical locking plate, with or without cages, and spacers like the C-locks, Fitzbolt, and the Sin cage. So this is the Harrington rod. Don't do this. This doesn't work. I'm just showing you from history-wise. And this Harrington rod is a human device. It's not been used in humans anymore, I think. And it got these hooks, and these hooks are entering into the vertebral body, and then you can distract the vertebral bodies. And with distraction, you may get some decompression. But the center of the problem is not at the center of the device. So that is a problem with this apparatus. And these hooks in the bone, these are stress risers. So there's a lot of stress on this hook. And the hook is stronger than the bone, so the bone may break. So we have seen complications with the Harrington and rod distractor. Why did we use it? Because we had nothing else. There was no other device at that time. But it's an unstable device. We've seen implant failures, focal stress point at the hook ventral process of the vertebral body. And there's certainly not going to be any spinal fusion with this device. Another technique that has been used, this comes from the literature, this is the Lubera plate. A Lubera plate is a plastic plate which is used on the spine. It's actually a very nice plate for a certain type of spinal fractures, but not for wobbler. It's just not strong enough. It's an excellent plate. The Lubera plate is a plastic plate that is molded around the spinous processes, excellent for lumbar fractures, but not for the wobbler. Here we can see the device, the plastic, of course not so clearly visible on the radiograph. It's fixated with screws. Here's a screw in the disc space, should not be there. And then with distraction, you see some decrease of the compression. This is the post-op image, still showing you the myelogram. And then 1 week post-op, we can see failure of the device. The screws are coming out. The disc has collapsed again. Compare it with this one. So it's just not stable enough. Then the pins and the bone cement, big pins, Steinmann pins, are used that enter the vertebral body, and they go up into the pedicle. So this is not in the spinal canal, but going into the pedicle. And then these pins are incorporated in bone cement. That's the idea of this technique. And there's modifications to this technique. You can use screws and then incorporate them in bone cement. You can bend the pins in a tie-in configuration. But essentially, all these techniques, if you use the bone cement, you have a big blob of bone cement sitting here on the ventral side of the spine. So it takes place, and the structures around it, they may get impaired by this bone cement. Think about the esophagus. So we see problems with swallowing in these dogs, or we have seen that, and that's why we abandoned this technique again. And if the pin is not in the right place, of course, you may enter the spinal canal, or you may damage the vertebral artery, which runs alongside the spine here. So numerous complications are seen with this technique. We don't do this anymore. This is another example, 10-year-old Doberman. Here we see some calcification of the disc. But that's not the problem side. The problem side is C6, C7. We see the disc narrowing, and we see the compression on the spinal cord. And then our pins are put in place, and the cement is molded around the pin ends, so the pins or if you use screws, the screws are left sticking out, and they are incorporated into the cement bridge. But then if we follow this case along, so here this is the post-operative X-ray. Good decompression. We can see the myoprime still there. If we look at the compression before surgery and now after surgery, it's a good decompression. But then in the follow-up, we can see that the compression recurs, the distraction doesn't hold. So we have, again, problems at that site. And also this dog showed problems with swallowing the food bolus because of the blob of cement that is sitting there. It's not visible on this image, but let me see. Yeah, disc narrowing. Okay, so pins and cement bridge, we don't do that anymore. Too many complications. And then this technique appeared in the literature, and mind you, this is already 20 years ago. Is it? No, it's maybe 30 years ago. Yeah, this is 30 years ago. That's incredible. This technique is 30 years old. It was the first technique that described putting something in between the vertebrae. And this device is called a washer. It's a metal cylinder. And this metal washer was put into the intervertebral disc space and then fixed, not really fixed, but it was held in position by one screw. And actually, this is a very simple technique. If we talk about this specialized surgery, all the techniques that you have seen are quite dramatic. This is, in that light, very simple. And it worked. So this one was done a lot by groups all over the world, and it showed that these dogs improved neurologically. And we also started doing that technique, and I'll show you some of the surgical images. So this is a Doberman. Important, every time you operate these dogs, then your ultimate aim will be spinal fusion. So you should incorporate the proximal humerus in your surgical site, where you are going to harvest some cancellous bone. And also important, do not overextend the head in surgery. So I made a note here that the nose here is pointing upwards towards the ceiling for positioning. If you do this, you may get a very nasty complication. You may, because this surgery takes maybe 2 hours, 3 hours, and if you put a dog like this, under anesthesia with total relaxation of muscles, you may get brainstem necrosis, and the dog will not wake up after surgery. So this is too much extension. Make a note that you support the neck and that you have the nose pointing upwards. So this is our routine approach, the ventral approach to the cervical spine. This is the trachea, and here we have the midline incision in the longus colli. So, and the longus colli here is visible on the ventral side of the spine. And then we start orientating ourselves on C5 and C6, and we find the exact place where we need to go. And then we expose the bone, and we expose the disc, and then we fenestrate the disc. But we do not remove the bone. So we do not perform a ventral decompression. We keep the bone. That's important for the technique with washers. We only remove the disc. You can see here, the disc is incised, and then we take out the disc, and then we put distractors in. And this is a very simple instrument. It's a distractor which is introduced and then turned 90 degrees. You can see that here. And that distracts the vertebral bodies, and that allows taking out more tissue, more disc tissue, to really make space for the washer. So this is our distractor, and it comes in two sizes, 5mm and 7mm distractor. And also we have washers in two sizes. Very simple instrumentation, not expensive. This is not more than 50 or 100 euros in Europe. And the washers are also not expensive. This is stainless steel. So quite attractive cost-wise. This is the washer. So with the distraction maintained, you see here the distractor on the side of the on the sideline here. We introduce the washer and then push it in, or we can actually hammer it in. Use an instrument that hammers this washer in place. And you see the washer here, and then we drill a hole, measure the depth, and then a screw is introduced in the center of the washer. And then finally we take our cancellous bone and we put that on the spine. And closure is routine. So here you can see the post-op result. This is the pre-op myelogram. Here we can see the post-op myelogram. And we see a very nice decompression, the washer in place, and the screw sitting in the center of the washer. So you also see the decompression on the dorsal side. It's very nice. You can see the decompression on the dorsal side, but also on the ventral side. Just by distracting, by linear distraction of the vertebrae. This is the dog 1 day after surgery, and that's the true advantage of this technique. It is simple, it is fast, it has low comorbidity, no major complications. The dogs, they walk the next day and they go home in 1 or 2 days. However, nothing is ideal, of course, so this story doesn't end. And we followed washers along in time, and here you can see post-op at 4 months, and you can see subsidence of the washer in the vertebral body. We see huge spondylosis, so we get spinal fusion, but by spondylosis. We see slightly migration of the screw tip into the canal, which is maybe worrisome, but it's still under the ligament here. This dog did not have any clinical signs, showed wonderful improvement, no neurological signs at that time. But it was not so lucky, because at 2 years after surgery, it died from a stomach dilatation, volvulus. And then we asked for the spine segment, so owner allowed us to take out the spine, and we processed that into a bone specimen. And you can see nicely this washer and screw sitting in the center of a huge bone bridge. So we have very nice fusion, but there is another thing to be seen, and that is, look at the adjacent segment here. And compare it at 4 months and then at 2 years. So we have complete ankylosis of this part of the spine, but it has put a lot of stress on this part, and this led to degeneration and collapse at this site. Not clinical signs, but this is what we call adjacent segment disease. So, summarizing for screw and washer, it's simple, low complication rate. We see arthrodesis by spondylosis. It allows treatment of multiple sites. It is not stable. It's only one screw holding this device in place. We see end plate subsidence. And bone-to-bone fusion is not possible, at least not there where the cage is, not where the washer is. The washer actually blocks spinal fusion. But this concept of putting something in between the vertebra, that was the start of, at least in the veterinary spine surgery, of taking this technique to another level. So from that moment on, you see that groups all over the world start to report on interbody spacers, or cages. So this is a cage. This is just a hollow device, usually metal. It can also be plastic, and it's put in between the vertebrae. And if it is plastic, you don't see it, but it has little marks in there, these radio-opaque markers that show you that there is a device in the vertebral disc space. And in this case, it was protected by cervical locking plates. So you see interbody spacers, and this is a nice study by Frank Steffen, and he also showed that through this cage, through this hollow structure, you will get spinal fusion. So summarizing for all the surgical techniques that I have dealt up to now, Da Costa made a nice review on that, and you can see that the results are fairly similar for all these techniques. Around 70 to 80% surgical success. But remember, these are retrospective studies, low number of animals, no control group, and there may be a surgical bias in these studies. So what have we seen in the last 10 years or so? Well, these washers have been further developed into interbody cages. And this comes largely from the human field, where we have seen an enormous development in spinal cages. And they may be resorbable or non-resorbable. Most of them are not resorbable. They may be titanium or PEEK. PEEK is sort of a plastic, polyether ketone, which was introduced in the orthopedic field in humans, became very popular, and also found its way to spine devices. And still, at this moment, a lot of spine devices are made from PEEK. PEEK is very similar to bone biomechanically if you test it in the lab, and that's the advantage of PEEK. However, the disadvantage of PEEK is that it doesn't really like bone. Titanium likes bone far better than PEEK. So wherever you put titanium, bone will grow into titanium, but not in PEEK. So you can stimulate bone growth in PEEK by using osteoconductive materials, and they are also out there on the market. Or you can use cancellous bone. And there has been an explosion of spinal cage development for humans. You see here only a limited selection of all the cages that are out there. If you Google for cages, spinal cages in humans, you will see all the images that are put out there by the companies. Titanium, PEEK, different devices, different shapes, for the cervical spine, for the lumbar spine, all for humans. Big cages, small cages, collar cages, this is titanium. Cages with screws, and so a lot of modifications. Cages with a plate. And they are used in the cervical spine and in the low back in humans. And they are used standalone or protected by instrumentation. And if we look at the veterinary market, there's only a couple devices. So there are not more than 2 or 3 devices out there for veterinary use. Rita Leibinger is one of the companies that puts out a cage on the market. Rita Leibinger is known from the TTA Rapid procedure. So they put out these cages for the TTA Rapid procedure for the stifle surgery, ACL. The cruciate deficient ligament in dogs, Now, if you look at this row of cages, and you see what they put out on the market for the spine, you see the resemblance. And this tells me that they just used the same technique. These cages are 3D printed. I know that the owners of this company, they come from the medical field, so they have seen all this development in the medical field, and now they have introduced this into the veterinary field. Using 3D printing techniques to make a row of cages, and now the surgeons can select the right size for the animal. And this is a standalone cage, meaning that no plate is necessary, but it is held in place by tiny little screws, 4 screws. So this is an example of the C-locks in a dog with cervical myelopathy. You can see here the cage in the invertible disc space, and it's fixed with 4 tiny little screws. When I first saw this concept, I had some doubts about this. Why? Because the screws are quite small, and 2, the cage is quite small in comparison to the end plate. And it's not so in this image, but it is so in the other image. If you look at the width of the bone here, and the size of the cage, it's quite small. So this is a stress riser. And if you look at the cage technology in humans, it's very clear that over the years, they developed cages with a larger and larger footplate. And why is that? Because with a large footplate of your cage, you decrease the stress on the bone. And that means less complications. Well, the C-locks has been used for quite some time now in the veterinary field, but not much has been published about C-locks. And I just Googled for this presentation, and just this month, a paper appeared on the use of the C-locks in a fairly large group of patients,